Hekima podcast. You're welcome. I'm the moderator of the day. My name is Raymond Mugume. I'm a psychiatrist. I'm a Rotarian from the Rotary Club of Kampala South. And I also run with Show and Steady Hikers. I usually do every Tuesday and Thursday. But that's not the main point why we are here. Why we are here is to understand why mental health research should be assimilated by the public, or why the public should understand what mental health research is. Now, when I talk about mental health, usually people think about mental illness. But what I mean by mental health is, are you able to deal with the normal stresses of life? Are you able to go to church? Are you able to go to work? Are you able to hear from your loved ones? Is your appetite good? Can you sleep? So there are many things that are encompassed in mental health. And when you talk about research, we are literally comparing data or information from here and information from outside. For the longest time, we have had that data that we use coming from outside countries, outside East Africa, outside Africa. And sometimes it does not translate into if we are doing better for our patients, if we are doing better for our clients. And so that's why we are all here, to understand why should we be interested in doing mental health research. This podcast is supported by APHRC, and it's part of the Hekima project, which is to digitize. The word is psychosis, and unfortunately, I haven't found the word in my Runyankore to describe what that would be. But in Africa, it is just digitize records, in short. And other than that, we want to perhaps get into a few facts, right? Get into a few facts of that every day globally, 1 in 7 people in the world is suffering with a mental health disorder. And these disorders or these mental illnesses do affect your life, and they disrupt life. Once they are untreated, if they are left untreated, you find yourself, your life is very disrupted. Like there is a long-term suffering that comes with that. What this podcast is about is to make sure that, one, we understand why should we be involved in mental health research? And two, is to understand how does this research that I'm talking about benefit you, the listener, or my grandmother in the village, or the people in Kafunjo Mbara. How does that support them, okay? With me, I had to call a few colleagues to join me in dissecting this. So it will be a conversation of sorts. And I have Auma, Rita, who is from Hearts to Hearts Foundation. Spaces. Oh, yes, Spaces. Thank you. And then I have a colleague now, but who is my mentor, who is a psychiatrist as well, who is a family man, who is a father. The only thing he doesn't do is run. At least he tries out with swimming. Dr. Kizza Mwesiga. I want to now give them the floor to at least welcome the podcast. Rita, how are you today?
I'm fine. So, my name is Auma Rita.
Oh, yeah?
I am a lawyer by profession.
Great.
An author of 2 books.
I keep dreaming when I will write a book.
An author of 2 books. And the head of a mental health organization called Heart to Heart Spaces, like you said.
You're welcome.
Thank you.
And then, of course, the man that I usually call him the Don, actually.
The man, the myth, the legend.
The legend, the myth. Dr. Mwesiga.
For me, as you were talking, I think I was proud because you're my mentee. So I've done a good job.
Thank you.
And so I'm a psychiatrist, senior lecturer at Makerere. What do? I do many things, but specifically for this project, I am the principal investigator.
Yes.
So since we're going to talk about research, that's like the head of a research organization, a research group, funded by APHRC and Wellcome Trust.
Yes.
Looking to digitize psychosis records at Butabika.
Oh, thank you. So, Rita, would you like to grace us with that conversation on what could be your lived experience with mental illness at this point?
So I had lived with mental illness for 10 years, undiagnosed. There were symptoms, but I didn't have a language for it. I didn't know for the life of me why I was sad for long periods of time,
Yes.
or why my brain was engineered to me unaliving myself, of which I had 4 attempts before diagnosis. And I didn't know anyone. I didn't have the African perspective to it. All I knew about mental health was you go to a therapist, white people go to a therapist, there's a beautiful plant in the corner and a big sofa, and you sit and you tell them about your problems.
Yeah.
And I also thought it was for rich people. So,
For rich people?
Yeah. Because why would you pay money to go and just sit
And
in
see
a
a
sofa?
therapist, right?
And see a
Yeah.
therapist. Yeah, so when at some point on my 4th attempt, I talked to a cousin. I spoke to a cousin who was the only one I knew had gone through mental health challenges.
Yes.
And she asked me, "Are you ready to get help?" And I remember asking her what type of help. So she says, "You might not be well, you might need to see a mental health professional." So I accepted to get help. But even in accepting to get help, I thought I was going to get it like from a private fancy hospital like I'd watched in TV.
Which are
on
we
TV.
looking at, by the way?
This is 2019. It's forever ingrained on my mind.
2019?
Yeah.
That's like yesterday, before COVID came in.
Yeah, before COVID came in. So it was still a taboo. So I realized I've passed the private hospitals and
Yeah.
I was being taken to Butabika. At that point, I start to wail because I was like, how can I, as a lawyer, be a mad person? I still had the negative connotation to these terms surrounding mental health and mental illness. So
Only recently, by the way, got to know that Butabika is just, it's the name of the area.
Yeah.
Like the whole area is called Butabika. And then somehow, since the hospital is already there, it took up the name of the area.
exactly, but there
But
is
it the other way around, so that the area got its name because of the hospital.
interesting.
No, we would have to ask the
So the area got its name. So in the old days, there were no mental health hospitals. There were mental health asylums.
yes.
They were like prisons. So across is the former prison, Luzira, upper prison. And then across it is the
Butabika.
Yeah.
The asylum.
The asylum for mental illnesses. So the area got its name from there.
That's interesting.
From
those asylums that
the
were there.
asylum.
the asylum that was there many years ago.
Then I think the one who told me the story cooked me up. Cooked
It
me
was
up.
probably younger.
Yeah, totally.
So I end up going. I get my diagnosis. When I got it, I cried. I didn't cry because I was angry or in pain. I just cried because there was a language to explain what was happening in my brain and what was going on.
Did you understand everything they were saying?
So no, that leads me to the next part. I went and I'm so passionate about research and new things and understanding. So I went and watched all TED Talks on mental illness and mental health, and they were all white people.
There was no black people black
There-
person that had been featured.
By 2019, there was no TED Talk I watched that had a black person featured.
Okay, so first wait. So in Butabika, how many people did you see there
There's so many.
at that point?
There were so many because I was first an outpatient, then I became an inpatient in a private wing, and the private wing was full. I don't
Was
know how
full.
many rooms they
And for
are.
some reason, we are not
Yeah.
on TED Talk yet.
Yeah.
But then the other day we had TED Talk in Entebbe. I had thought maybe we should maybe formulate a TED Talk. What do you think,
Have
Dr.
they talked
Mwesiga?
TED Talk, what
about
for?
a
What was the
TED
TED
Talk
Talk?
on mental health?
So there have been TED Talks on mental health. I know.
But there is no black person, as she said.
Recently, a recent past, Professor Nachmuli has a TED Talk. You should. Very nice.
Yes.
So
Yeah,
it's
yeah.
recent.
Yeah.
Was it like this year or last
No, it is
year?
No.
like 3-4 years ago, I think. I came
Don't
across
ask me
it.
about years. I'm very poor with years.
I don't
Hey,
think. 2019, I needed to understand and I didn't find one.
So you go on searching for TED Talks.
Yeah.
Those ones are on YouTube, by the way.
Yeah, they're on YouTube. They're free.
I'm curious. What did you want
To know.
to know?
I wanted to understand my diagnosis better because when you go, they tell you this is your diagnosis, come back next time for the next session.
Okay.
So I needed to understand what I was really dealing with better, and I needed people like me who are on the same journey to healing to tell me, you know what, it's a diagnosis, you're going to be okay, these are things that you can do. It's different when a doctor is telling you these are things you can do and it's telling you, oh, exercise helps. Like, man, I can't get out of bed. What do you mean?
Yes.
I should run.
Yeah, we say this all the time. We say
Yeah.
this all the time.
Granted, as I have healed on my journey, I see the importance of it. But right then, at the point of diagnosis,
Yeah.
I needed someone like me to tell me it's going to take time, but give time, it's going to work out.
You came timely on this podcast, to be honest. You came timely. So why then, what does this mental health research for the public mean for you? Why is it important for you that you're telling us this part of your life?
I think for me, it will help people like I understand that there are others, but it will also help get solutions to the things that the gaps that are existent that haven't yet been resolved or gotten solutions for. An example I can give, research was made after COVID about the 14 million Ugandans. And then the conversation about mental health, I feel, went up the graph.
Yes.
Because now there was a statistic, people were concerned, people were talking about it. I feel like that's one of the things research does. It sees the elephant in the room.
Yes.
Everybody now sees the elephant in
The room, yes.
And then they get issues on how to address this elephant.
I think what
Should we
I'm
take it
hearing
out?
from what you're saying is that research, apart from, it gives you comparison, right? That there are other people so there are other people that could be on the other side of the mic, right? That they have listened, and then they are comparing, have I had times where I don't sleep? Are there times where I've felt...
Why I don't eat?
Yes.
Are there times when I've felt like I want to end my life?
Yes.
Is it normal?
Yeah.
Is it not normal? So it brings light to the thing that's happening. But also then the people who are in the field are like, everybody has noticed the elephant. Even I want to join in the solution to solving this problem. Today in the morning, I was on another podcast and I was telling them that at the beginning of my advocacy journey, I would hear, there are only 30 psychiatrists in Uganda. I'm like, 30? So how do they distribute themselves?
Man, you should know that at least now we are 81. That is the good journey. Yes, we are now 81.
But now, like, people got attracted to it.
Yes.
I believe now I have students in medical school reach out and say, I really want to be a psychiatrist.
Okay.
I would really want to specialize in this and get a solution to this and this. But those are some of the things research comes with. Before, maybe Dr. Mwesiga would go like, psychiatrist is a good field, and they'll doubt that, like, you might be like your patients. I might not be.
I think for him,
interested.
that's the interesting bit. So, Dr. Mwesiga, from what you've heard from, what we've heard from Rita, are there challenges, right, that you've found within your practice? I know that you've been here longer than I have, but are there challenges that you've faced that could have prompted you to even say, you know what, we need to have mental health research and it needs to be known by the public?
So Rita knows because we've been together for a while. Many times we keep reading, and I always tell people we have to read. You read stuff and they will tell you that it works in the UK, in the US, right? Ethically, we are supposed to do the same things here.
Yes.
So I'll come to Rita and tell her, I want to try out this thing, right?
Yes.
And Rita, being knowledgeable, will ask, does it work? Does it work? And she's not really asking whether it works, yes or no. It's does it work for me? And I think one of the struggles we've always had in mental health and psychiatry is that there are a lot of differences. Her story may sound similar, but it's totally different. And I would never see another patient like Rita. So research helps you sort of like overcome that. It says, for the most part, this works for most people.
Yes.
But as she said, and that's why there are so many TED Talks that were, non-African. The next question then is, what works for an African from Uganda in Kampala? And one of the struggles we probably have is that we know things work, but we don't know how they work, so we can't explain a bit further. We don't have a cultural input, right?
No,
so
we
we need
don't.
things. We need things that work for Ugandans and stuff like that. So we need people. And that's why for us we're interested in research, and that's why we're actually interested in data.
What is data, by the way? You keep
So Rita talks about suicide. Data is information. So people will tell you about what they ate for breakfast. If you go on social media, someone will tell you what they ate for breakfast, how they slept, right? But no one will ever tell you about their struggles, their mental health struggles, maybe apart from Rita.
Auntie Rita we also invited her.
Yeah, so
Said,
also
please, you come.
And also she never used to, and again, I've known her for a while, so she
Yeah.
also never used to talk this much about her mental health struggles. It was also
Yeah.
struggle.
Rita, nga you're doing well.
Yeah, so she's doing well. So
Yes.
Feeling.
it's because we don't have enough information
Yes.
that we can't come up with this middle ground of what works best, what should we recommend, and things like that. So what happens now is that we have very limited solutions, right? So she says she cried because she was going to Butavika. And people do still cry up to this day, right? And maybe we have never asked ourselves, what's a different treatment model? How should we do things differently?
Different, yeah.
Should we change the name of the hospital? Should we... So like no one has ever asked...
Those questions.
To my knowledge, no one has ever asked if patients like the name Butavika, right?
Maybe we should put out like a
Maybe we
form
should
of
put out like a poll.
A poll, yeah.
Yeah. And that poll is the one that would inform us. So maybe we would call it mind wellness being or something like that.
Yes.
And maybe fight the stigma. So where we come from is that we don't have enough information about so many things that we need to do.
Okay.
Okay? And that's at so many levels. It's about how to deliver the service. So I know Heart to Heart Spaces creates environments for people to attend therapy. But how did that come up? She asked people where they want to go. And the truth is they don't come to the hospital, right?
Yeah.
So she got data and figured out that, look, people don't want to come to the hospital. They want to get services, but they don't want to come
To go to hospital.
Now, if you don't keep getting such information and then acting on such information, you then keep struggling.
Oh,
And yes, I feel personally that, yes, we're 80 psychiatrists now, but I still feel we struggle a lot. We struggle a lot because we don't have good information to tell people. We don't have... So we can't tell people drug A works better than drug B. For Africans, for Rita.
For Rita, no, we can't.
Or
we
for
can't.
Raymond, or for myself, right?
No, we can't.
And unless we do that, we are going to keep struggling. We are going to keep being lost. So mental
So
health
you're
for the
saying
public,
that sometimes you found yourself lost in that discussion.
I'm always lost. She knows. She knows. We've sat together and I've asked her, okay, so now what do I do? Right?
Yeah.
She's
I thought that was for me alone, but
Yeah.
except that now that you've brought it out, I can now freely talk about it as well. That I find that challenge.
Yeah, so you get challenged, and it's not because you don't have the knowledge, but it's because you don't have enough information for the people in front of you.
Yes.
So that comes to the second thing. When we ask people to tell us, there are two aspects we are struggling with. On one hand, there are many regulations,
Yes.
but then on the other hand, people have been taken advantage of.
Yeah.
So that's the balance. And people don't understand research. Either we're in research to make money, or we're in research to get your blood and disappear and make drugs, and stuff like that. So the idea behind this is that, look, we can simplify mental health research such that the public understands and such that the public gets more involved in these things. I'll give you the last big example, and she's talked about suicide. We have a clinic in Makerere, and the rates of suicide ideas are so high, right?
Yes.
And we probably must have a study to understand why.
Well, we have so many
Yes.
suicide ideas.
Yes. Okay.
Mm.
But try and go to the public to talk about suicide. Okay. Or research on suicide.
Or is it because of how we communicate?
Could be how we communicate, but that's the idea. That how do we communicate not just the illness, but the solution, which is more information. How do you do this research?
Okay.
So where I work, we've done a lot of things. We've introduced a lot of things that are done abroad, but always there's that issue. Does it
work for?
Then I will tell you, a study done in America on 1,000 people. And everyone after that says, well,
Yeah, well.
And
I will,
in Uganda.
and in Uganda, and
In Uganda, we haven't.
we think it works because it worked on
On
and then the next question is, okay, so why don't you find out? Then I tell them, okay, to find out, I need to do A, B, C, D. Okay? So that's where we're coming from. That's where Rita and I are coming from.
Again, I want to remind you this is the Hekima podcast, and it is supported by APHRC. That name, APHRC, and Wellcome Trust. And we're just going to take a short break, and we continue the conversation. So this is the Hekima podcast, supported by APHRC and Wellcome Trust. And back to the conversation, mental health research for the public. So, Dr. Emma, how and why should Rita get involved in research, in this mental health research that you talk about?
No, you should ask Rita. Because I am biased. So no, me, I want Rita to be.
For you already biased.
I'm already biased.
Okay.
I need Rita's information, and I need the public's information.
Okay.
So I think it's important.
Rita should answer the question. Rita, why do you think you should be involved in this research?
I really think it's important for us to be involved in the research because we're the ones that experience everything firsthand. We are experiencing the mental illness.
Yes.
We are experiencing the solutions or the medication you're giving us. And we know firsthand how it's affecting us. So most times you go to a doctor and he has already read his books, granted PhD, masters and what.
Why are you attacking me, by the way? Like, why are you attacking me?
Okay,
Like, why are you attacking us?
and you're telling him this is how this specific drug is affecting me.
Yes.
But he's stuck to the textbook and he doesn't view you as an individual. I believe that healing is different for everybody. Works for Raymond, won't work for him, and won't work for me. So I think when we collect different individuals' perspectives on how these things are affecting them, the pot is way bigger. Of the results, the pot where you get the results from is way bigger. And also,
So we want many cooks. At the moment, we just want as many cooks.
I don't think it's about many cooks. I think we want to when we hear a story, we can assign in the book to someone closer, right? Because
Oh,
what she's
yes,
saying,
yes,
what
yes.
she's
Yeah.
saying is that the book is sort of very distant. If I may to understand what you're saying.
The book is very distant. The book might say, let me give an example. Lorazepam works on a patient, but it only works for 4 weeks.
Okay.
But then you go to your psychiatrist, he tries different medication, and maybe all that medication doesn't work. But then he's also hesitant to keep you on the lorazepam because the textbook says
Addiction.
4 weeks addiction. Yeah, so I feel like when you listen to individual stories, it gives leeway to these different stories to come up and more research to be done on a specific thing.
So if I may come in on defense of the clinician. So yes, the textbook says 4 weeks, but now on the other side, why we're here today, research allows us to figure out if the 4 weeks is actually the 4 weeks. And it goes back to my original point that she may need 6 weeks, okay?
Yes.
And the profession has rules of how I can move to 6 weeks.
6 weeks.
And we want the public to understand how we move from, 4
4
weeks
to
to
6
to 6
weeks.
weeks.
such that on her side we say, look, if you want to reach 6 weeks, this is the process we have to do, and it can't just be about you. We have to go and do A, B, C, D.
BCD.
Okay.
There's still regulations.
There are still regulations
we talked
there,
about.
the ones that we talked about. And then it's also to tell her that, look, there are like 10 other people like you who actually need 6 weeks, but we need some more information from you.
Yeah.
And now it's the public then to understand what that entails. And that's why we're talking.
Well,
And that's why her and I are sort of like thinking, look, the public need to understand what mental health research
Such
is.
for the public, yes.
It can't just be anymore about us, the scientists. And so Wellcome and APHRC have what they call, not only them, but they're very specific now on what they call the lived experience.
Yeah, people with lived experience.
And what she's talking about is that someone who has gone through it, and they have a saying, nothing for us
without us, yes.
And I love that statement. So it's basically saying, look, if you're going to ask us to swallow lorazepam for 6 weeks, and I told you, so I always tell undergrads, my favorite lecture in undergrads is, first thing I tell them is, Friday night, get chlorpromazine, right?
Yeah.
200 milligrams, swallow it. He knows, I've taught him.
I did.
And then, such that in the morning, you understand
How it feels.
How it feels like before you go and prescribe 800 milligrams. No one ever does, luckily.
No, actually, I should tell you.
You did.
You did 800?
I know, I did risperidone, 2 milligrams.
Yeah.
But the next day,
Very bad experience.
very bad. I couldn't walk. I couldn't even raise my head. I thought I had actually gotten sick.
Exactly.
Then it hit me that, oh no, yesterday you did that thing that they said.
the
I don't think
lecturer told.
yeah. So it's already the medicine, but now I cannot.
Can you prescribe a large dose of risperidone? No, you can't.
And I've not only done with that, I did also with carbamazepine, I did with the olanzapine, like to understand, because every time like the patients would come and tell me that I feel so heavy.
Yeah.
I can't do anything.
I can't do anything. Then the next thing that, before I would say, drink water.
Run.
Run.
Be in the sun.
Be in the sun. But the truth is
I don't think I've told you that. No, that wasn't me.
That wasn't you.
that wasn't it.
That wasn't you.
But after that, right? After I did that, there is no way. I find myself that now I reduce the dose until they can be able to function or switch.
So now that's the lived experience of research. So now what we want to do is to help patients understand that it's not as easy for us to just all of a sudden
Switch, yes.
If the package has said 10 milligrams, all of a sudden give 5 milligrams. If we have said CBT for 12 weeks, now do 6. So we want to help them understand how they can talk to us such that we can then have this journey where we undergo that change. So the university hospital we told you about. So we actually decided, because of patient feedback, we now give half of a certain drug, half a dose.
Yeah.
That is now a research program, and that picture, that model needs to be like expanded. Okay, so we need to start having these discussions where patients are saying, look, we want to sit under a forest, under a tree, right?
Because you see, Rita said that when they did their survey, they found that people don't want to come to hospital.
And we still know people don't
right?
come to hospital.
So which means that whether you're under the tree, whether in a taxi, you can still give us the data.
So Friendship Bench,
The Friendship
Bench
has worked
very well,
Yes.
right? Because it is sitting with your grandmother on a bench and you talk about your sadness, right?
Yes. So then do we need to be always under these shelved offices, good lighting?
We do not, but the public needs to understand how we move from
the offices
hospital
to be under the tree,
to be under the tree,
or to be in church.
or to be in the church, in the bench. The process that we go through, that's what we want to. So over the next few weeks, and all the lectures we want to have online and on Zoom, is what we want people to understand.
Oh, we are also having lectures.
Yes, so we're going to have online lectures.
Okay.
And the idea is to teach guys that, look, we are looking for data. What is data? Right? We are talking of ethics. What is ethics?
What is ethics?
We are talking of methods, tools to collect data.
M-Pesa, moral, M-Pesa, ethics. Yeah?
Is that?
Right?
No,
M-Pesa is...
No, we are tools.
tools, okay. And
So-
Mugambi ethics.
We want to teach people how the information gets shared.
Yes.
Many times we take people's blood.
Blood.
What do we do with their blood? What do we do with their saliva?
They will say you want
Where
to
do we take
witchcraft.
Where do you take it?
Yes, we are not using it for
But they
witchcraft.
say psychiatrists are what are land witch doctors.
No, we are just land humanists. We understand the human being.
The new word is humanists.
Yeah, I think we are humans. So
Yeah.
we are the people who will ask, and how does that make you feel?
Yeah.
Right?
What's the meaning?
What
What
is the
meaning
meaning
do you derive from that?
Good.
What does it mean for you?
For you. Because other people will ask you, won't ask you what.
They will ask you, Musuja, wakufunye ddi? When did you get the malaria? How many days?
Yeah. So it doesn't mean what it means for
Yeah.
you, right? And I think that's the important thing.
Yeah.
So that is I think, Rita, in regards to what we have talked, do you feel now you want to get involved in research more? Will you tell your people when you're seeing them? Because I think what I understand from this conversation, you see, one of the good things I thank God for is that to have a good mentor.
Hey,
When you
I thought you were about to say you're both a patient and you also have a good mentor.
Yes. To have a good mentor. Why? Because I think they see in you what you do not see in yourself. So for a long time, I know that I don't like clinical work, right? But when it comes to talking, I will talk. It is in this talking that we might need to know how we communicate to our patients about the things that we know.
Yeah.
But how do we package that? We still need data. We'll need to know, like you, Rita, how do you want me to tell you about your illness? Right? Do I wait for you when you are at the first time or later when you come for the second visit?
So I think just to chip in there, so and why we need to understand research is that you can't only ask Rita.
Yeah.
No.
Because you cannot make a service, although there's precision medicine, you have to make a service that is for the majority,
of
people
Yes,
people
yes,
in the
yes.
pot.
in the port. So the more people we have, the more we understand,
Understand.
especially for mental health.
Yeah.
Yeah.
And that's why we're saying, look, we need data. We need data.
We need to compare and contrast. Compare and contrast.
And once we compare and contrast, we find a middle ground.
Yes.
So I will confidently say that we do not know. Okay, now because of experience, we will know that the best drugs, right?
Yeah.
Or the best doses.
Yeah.
But we have not taken. But experience is not the best method of research. It's
Yeah.
probably
No,
the
it's not.
lowest level
No.
of research.
And it takes a long
And it takes a long time, right?
Yeah.
So we need to figure out ways of how do we get this information. And again, I always go back to for Ugandans, for Africans, culturally responsible. So that's why we're interested. That's why we're interested in Rita, and Rita's lived experience. I have enjoyed.
Okay, so like what would be, one thing that you would want to live in the ears of that listener who will tune in later?
I think it's don't be afraid to be part of these research programs, because when you do that, it's like a domino effect. You're now being part of the solution. And one of the things I've learned on my healing journey, when you help others, the healing is, I don't know if it's faster, but it's also more meaningful. You get
The healing that is meaningful, and it might be slow, not faster, but it will be more meaningful.
It's more meaningful and impactful, yeah? Yeah, so that's why I'm always excited when it comes to research, because I look back at my first experience.
2019.
Then I look at the experience of getting a right fit. 2020. Experience of getting a right fit. And now when someone says, hey, do you want to be part of a research study? I'm like, hit me up. What time? Where? Yeah, because I am that passionate about it. But I'm also passionate about the people who are coming behind me to find a better system.
So you're planting trees that you will not enjoy the shade for.
I will sit with them.
You will
in
enjoy
the shade.
You will enjoy the shade. You can keep it, but for now you plant the seeds.
For me, the tree I would like to plant is for people to there's been a lot of mistrust in psychiatry and in mental health over the years. And
is it mistrust or is it an awareness?
Mistrust.
I think it's mistrust. You need to hear what they are saying, right? You need to hear what they are saying. It's mistrust.
Okay.
People don't trust us because, one, I think they get better, but they don't get better in the time span we promised them to get better.
Yeah.
Yes.
Right? So we tell them, swallow this drug, and they ask us for how long, and we say, for
2 weeks.
2 weeks.
2 weeks. Then they
Then
come back. Then we add them, and
Yeah. We are never sure to tell them that you might take it for more than 3 to 6 months.
But the issue is, we also need to get the information of how long we should tell them.
Yeah.
Right? Such that we can give them
Tailored
to
our people.
We always call it precise,
Yeah.
precision medicine. Such that we tell you that, you know what, based on your height, weight,
and where you come from. If you're coming from
your,
Karamoja, vis-a-vis coming from Kashari or
and your genes and etc., you will need 2 weeks. And someone else will need 4 weeks.
Yes.
But for people to trust us, trust us again, unfortunately, they now need to give us.
What happens when those two people meet in a taxi?
Which one?
Or the one who takes for 2 weeks, another one who takes 4 weeks,
but
and they meet in a taxi.
if we have communicated well, and that's why we want this.
Yeah.
If we have taught them research, and we've taught them how we generate. That's true. But they'll understand how we do the study, what the results mean.
Yes.
What the results mean for a certain group of people in a very simple way, right?
Yeah.
Because even us, we have examined you before, and you know how people sweat at their finals. You were sweating the other month.
Disregard
Not
that.
from running.
Disregard
Not
that.
from running.
Not
Not
from
from
running,
running.
yes. But disregard it. Now it's okay. It's
Now
okay.
it's okay, you
Yes.
pass. So if people understand, because if we ourselves are finding it hard, right?
Yeah.
Then what about the
patient?
patients
What
and
about
the
the
public?
public?
Yes.
right? That's one. And
The ones who are taking care of the
of
patients.
caretakers.
And then the last part is we don't know everything.
No,
And
we
I think,
don't.
and I think this is working with Rita. I think what has humbled me is I used to be arrogant. She knows. I used to be the guy who knows it. I'd read my books.
Yeah.
I'd read my books,
Yeah.
right? And when you read a book, you get confident, right? Then they ask you a question that is so simple, but you don't have the answer. And then you have to be humble. Because someone can ask you a question like, okay, do I need to come back tomorrow? And you're like, okay, yes, for what?
That for what?
Yeah, just for what? Then you say to observe. Observe what?
Observe what?
For how long?
For how long will I be?
Is it the whole day? Is it
Yeah.
2 hours?
So you start becoming humble because you start getting perspectives that that you can't think of. And research, especially with lived experience and lived experts, will allow us to do that. Okay?
We'll be able to tell you, oh, okay, Kari.
It will be two-way because the way research is with lived experts is that. So, for example, now our project, we are digitizing files, right?
Yes.
But at some stage, we are going to ask Rita, because we are trying to figure out why people come back to
Rita is the emblem of people with lived
experts.
experiences.
Yeah,
Oh,
she's
congratulations. Bantu bawe. Bantu bawe.
okay. So we're going to ask Rita, what in the data should we look for that makes people
Come back.
Come back. Yeah.
Okay?
Yes.
So we know transport, and they'll tell us, no, that's not why we don't come
back.
Right? We don't come back because you shout at us.
Yeah.
So then we'll tell...
Oh, you don't come back because I wasn't convinced enough?
I wasn't convinced enough.
That I should come.
So then we'll ask the data, look for situations where, like the clinician writes, the patient was stubborn. Or,
Why was the patient
or
stubborn?
resistant?
Yeah.
Or refused to listen, right? And then we'll figure out, okay, so at the end of the day, we might say, okay, maybe for people to come back, this is how we need to communicate.
Communicate,
with
yes.
Yeah, and that's why for the project we have gone back to the data to sort of like
basics.
Look at the data. You might find I wrote, maybe in those years I wrote, Rita was reluctant, which or was unhappy, right?
Yes.
In her file, right?
Yeah.
And then if we look at enough files, okay, then maybe
You can get a
we can
theme
get an
for
answer.
what that's exactly.
So it's getting her story, balancing it with our need for information. Yeah, and figuring out what to do.
So thank you, Dr. Emmanuel. Thank you, Rita.
You're welcome.
This is timely that we have this conversation.
Yeah.
So again, myself, of course, what do you want me to part you with? Is be involved, right? First, subscribe. Second, listen. Listen as many times to what this conversation is. And plus, leave comments. Like on the down there, you just leave comments. As many questions, as many thoughts, as many statements, just leave them there. We shall answer one at a time.
And also share.
And also share. Share with your grandmother. Share. Tear. No, don't tear, but share.
Just
okay?
share.
Just share and be glued. Because once the conversation begins, what happens next is ask questions, get involved, right? Because I know that now research is open to have, you can also volunteer and say, I want to be involved, right?
Yeah.
We need as many groups of people with lived experiences to be able to have the data and have the discussion so that we can cater for everybody, right? In planning. And importantly, want to remind you that Hekima podcast, sponsored by APHRC and Wellcome Trust. And it's under the Hekima project, which is really to digitize files. Those files you've been seeing now, even to be a computer. So again, I will see you next time. Thank you, Rita, again, and thank you, Dr. Emmanuel, for being part of this.